Well, I was assigned this topic, 10 tips to optimize your obstetric anesthetic. I think that may be what's in the program, but I may not have exactly 10, but I hope to offer some suggestions about things that you can do, maybe not necessarily limited to labor analgesia, because some of the comments that I make will be applicable to any kind of anesthetic, including cesarean anesthetic. And you'll also notice some of the things that Shilpa mentioned in the previous lecture, I'll be mentioning as well. So we're covering some of the same topics. And again, I hope that some of these things you will find useful and will at least make us think about some of the ways that we practice. And I hope to present some things that maybe you might not have considered with regard to how we practice. Well, Shilpa mentioned this article, Why Epidurals Do Not Always Work, and it was just published a couple of years ago. And of course, it's one of the most frustrating things that we have in our practice when we place an epidural and it just doesn't work. And this, I actually apologize for this slide. It's a little bit small and difficult to read, so I'm not going to belabor the point on going through all these little details. Let's just move right on to some of the other issues. Well, you've all been to parties, cocktail parties, receptions. You get these little stickers you put on, it says, hello, my name is, right? And you go up you meet people, my name is such and such, and you say your name, right? Well, we also do the same thing when we go to meet patients. We introduce ourselves, and hopefully patients will introduce themselves back to us. Well, the way you introduce yourself actually may make a difference. Now, I understand I preface this by saying that I'm going to present some American data, that maybe there are cultural differences as we discuss these things in other parts of the world, but there have actually been some studies on whether patients prefer us to use our first name or our last name or a title such as doctor when we introduce ourselves. For example, it's a fascinating study, an evidence-based perspective on greetings in medical encounters. And the results of this were, again, it was done in the United States, so again, I emphasize there may be cultural differences, but generally patients prefer when we introduce ourselves by our first name. Now, for all the years I've been practicing, I would always introduce myself as Dr. Kamen. And after reading this article, I now introduce myself as Bill Kamen. I'm your anesthesiologist. And I can tell you that I notice there's a difference in the way patients perceive this. It just sets the tone differently. It makes for a more friendly tone. And I think it does make a difference. So, use your own judgment, understanding that there may be, as I said, cultural differences. There may be age-related differences, gender differences, various other differences. But it's very interesting that people actually studied something that whoever thought of studying how you introduce yourself. Okay, let's move on. Sit down. Now, this is something that I've also embraced in my own practice. Typically, when we go to see a patient, the patient is laying in bed, and we are standing next to the patient in bed, standing next to the bed. Well, when you're standing up, and the patient is sitting down next to you, Katsu, come on. Sure. Actually, have a seat right over there. Now, imagine he's laying on a stretcher, and I'm standing above him, looking down on him. That can be perceived as an intimidating or a confrontational way to deal with patients. They're laying down or sitting down, you're above them, you're talking down to them. It has a different feeling compared to... Sit over here. Does this feel different?
Yeah.
It feels different, right? It feels different. So, great. Just something as simple as how you sit, how you present yourself next to the patients makes a difference. What I do every chance I get, if the room is set up in such a way, I take a chair and I pull it up next to the bed and I sit down next to the patient. Believe me, it makes a difference. And I suggest that you might want to try that as well. The patients really notice, and the whole tone just changes when you do it. Move on. This is actually a study, so here you go. Sitting down on the job. New data finds that patients are happier when doctors sit down even if they don't stay long. What they did in this study was they timed how long the physician was with the patient and then compared that to whether the physician was standing or sitting. And what they found was that when the physician was sitting, the patients perceived that the doctor spent more time with them. So you can make a better impression by sitting. They think you're spending more time with them. All right, use nice words. We all like to be nice. Well, let me give you some examples of what I mean here. The way we phrase things, the exact words we choose, can make a difference in the way patients perceive our procedures. Now, this study, can words hurt patient-provider interactions during invasive procedures? That warning the patient, by the way, this study was done in a radiology setting with some invasive radiology procedures. And when they warned the patient that in words such, it's going to hurt, you're going to feel pain, things like that, that warning the patient in terms of pain or undesirable experiences actually resulted in greater pain and greater anxiety than not doing so. And this has implications for training and medical communication skills. There's been a lot of studies on this type of topic. For example, open versus specific questioning during anesthetic follow-up after cesarean section. The basic thing they did in this study was they saw patients a day or so after the cesarean and essentially asked the question two different ways. They asked, are you comfortable or are you having pain? And they found when they asked, are you comfortable, the patients said they were more comfortable. So don't suggest things like pain that maybe they might not be having pain. We all start IVs on our patients. Effective communication on pain during intravenous cannulation, a randomized controlled trial. Basically, they did a randomized study where they warned the patients that it's going to sting before the IV versus not warning them that. And that when they asked the patients how much pain they had, that the patients actually felt the experience was better when they weren't warned of a sting. So keep those words in mind when we talk to our patients. This is something called the nocebo. Well, I'm sure we've all heard of placebos, right? A very common thing. Well, placebo comes from the Latin for I shall please, or positive results by suggesting something positive. Like I'm going to give you a pill that'll make you feel better, even though it's an inert pill. Placebo. Well, nocebo is the opposite. Nocebo comes from the Latin for I shall harm, which means creating a negative effect. Another example, I'm going to give you a pill that'll make you sick. Probably going to make you sick. So recently, there's been a lot of work on nocebos. If you Google this or literature search, Medline, tons and tons of articles on nocebos. And it actually has some neuroanatomical correlates. Placebos can influence mu-opioid receptors, soothing, calming neurochemicals. Nocebo suggestions can induce more irritating neurotransmitters. So there actually is some real neuroanatomy behind this. This is a study that we did at my hospital a couple of years ago, and I think it's probably one of the simplest studies that I ever did, but also one of the ones that has the most impact. So it's titled Nocebo-Induced Hyperanalgesia During Local Anesthetic Injection. And what we did was we randomized patients prior to either an epidural or a spinal to either harsh words or nicer words, just for the skin wheel, just that part where you anesthetize the skin. And then after we did that, we had a blinded observer, someone who was standing outside the room and could not hear what was being said, came in and asked the patient on a 0 to 10 visual analog scale how much discomfort there was. Once they gave the number, the study was over, and then we proceeded with the anesthetic. So the study literally took 5 minutes per patient. And the harsh words were something I think that most of us probably do when we do these anesthetics. We tell the patient it's going to hurt, it's going to sting. Sometimes we say, this is the worst part of the procedure. Sometimes we say it's going to burn. I often see my residents will go at the patients with a needle. They'll say, here it comes, it's going to burn. It's going to burn, 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 it's going to burn. You know, and you can imagine you've got a nice, calm patient that's jumping off the bed when they hear things like that. So the nicer words were things like, you'll feel a small pinch, it'll be over soon, you'll be very comfortable. Okay? So a big difference in how we explain the procedure. What we found was that the pain scores were lower when they had the placebo suggestions compared to the nocebo suggestion. This was true both for labor epidurals as well as cesarean section spinals. So it made a difference. Patients perceived it difference. Now you'll notice there's a fairly wide variability in the numbers here. And the fact is some patients, we've all experienced this, no matter what you say, they're going to sit there and just be fine. And other patients, no matter what you say, they're going to jump off the bed when you hit them with a needle. So it's not something that works every time for every patient. But in general, if we're nicer about these things and we don't explain things in terms of pain or burning, but rather explain things in terms of comfort, it makes for a better experience. All right, let's move on. Dural puncture epidural was mentioned by Shilpa in the last lecture, so I'm not going to say too much about it. I actually only got one slide on it anyway. This was a study that we did at my hospital a few years ago. It was explained in the previous lecture, making a dry dural puncture. In other words, just making a hole, but no medicine injected spinally, and then the epidural anesthetic proceeds from there. They found a better block. I have to say the amount of difference in the block was fairly minimal, and I don't recommend doing this on all patients. Maybe you might want to do this on someone who has previously had a difficult experience with an epidural. Maybe if you have an epidural that's not working so well and you decide to replace it during labor, you might want to do this. But I don't recommend doing it on everybody. The reason it's underpowered to detect post-dural puncture headache. And we heard in the last lecture, we know from our own experience that using these small gauge pencil point needles, the incidence of headache is still very small, but it's not zero. So I don't recommend this as a universal technique, but there are certain times when you might want to try this. Well, how about positioning? Now, we all tell our patients when we're doing a spinal or an epidural to get in a certain position, right? We all know what that position is, but the way we tell them, what usually happens? Let me ask you folks, what usually happens when you tell them the various things that we tell them? They usually do just the opposite, right? Usually you tell them, push your back out, round your back, you put your fingers on their back, you say, push against my fingers, right? We've all been there, right? We've all used those kind of words. They almost always do the exact opposite. They pull their back away from you. Isn't that right? I see a lot of people shaking their hands. Yes, that's right. So, let's see. What do we tell our patients? The problem is we tell them to do something with their back. You push your back out, round out your back, make your back round, things like that. But in reality, this is something that is done from the abdomen. You have to tighten up the abdominal muscles or tighten up the gluteal muscles. If the patient has learned a maneuver that's sometimes called the pelvic tilt, you sometimes learn this in childbirth classes or in yoga classes. They learn the words, the pelvic tilt. But if they haven't taken childbirth classes or they're not a yoga master or anything like that, as most of our patients aren't, don't emphasize anything with their back. Here's my advice. Tell them to imagine they're putting on a tight pair of pants. When you go to put on a tight pair of pants, you've got to suck in your abdomen, right, to pull up those pants. You suck in your abdomen, your back is going to go right out. Works every time. I'd like everyone in the audience now to just imagine they're putting on a really tight pair of pants and they're pulling it up, right? You pull it up like this. And your back is going to go right into the right position. You tell them this, it works almost every time. The nurses look at you like you're a little crazy, but then they see the patient gets in the perfect position, and you've got a winner right there. So it's a simple little thing, but some of the most difficult patients will absolutely get in the right position when you use that analogy. Well, let's move on to something for cesarean section. Now, we place generally hyperbaric spinal anesthetics. After we place them, we usually put the patient supine, of course with some uterine tilt. Leftward tilt. And then I see some people will almost immediately put the head of the bed down, especially if the level maybe is not coming up, maybe is T8, T7, something like that. You want to get it up a little higher. It's now 5-6 minutes after the spinal's in. Put the head down. Well, I suggest don't do that. Leave the head actually in a little bit of an upright position. Now, these spinal blocks will take a good 10-15 minutes to fully set up. They don't set up. I mean, they're fast, but they're not instant. And there's been a number of studies looking at a slight degree of head-up positioning, 10 to 20 degrees of head-up positioning, just a little bit. Let the block settle in that position. It will eventually come up to the adequate level. Don't get excited. Don't panic. If the block is only T8 at 5 minutes, it's going to come up. Just relax, or as we say in the United States, chillax. It'll come up. So effective 10-degree head-up tilt on positioning spinal anesthetic for C-section. Oxford positioning. This is basically a variety of a head-up tilt where the back is kind of crunched and the back is up a little bit. But all these studies show that when the block settles in a position like this, you actually have less hypotension, you have greater comfort, better blocks, and less other side effects such as nausea and vomiting, probably because of the less hypotension. So I think it makes a difference, and the point is don't be too quick to put that head down. Just relax, a little bit of head up, and wait, and you'll be fine. That's what I just said. Okay, let's move on. So another thing, and this was mentioned very briefly at the end of Shilpa's talk about the programmed intermittent bolus. This is a relatively new concept of an epidural pump, which rather than giving a straight continuous infusion, will give intermittent boluses spread out over a certain period of time, using the same number of milligrams of local anesthetic. For example, 9 milligrams per hour as a continuous infusion versus 3 milligrams every 20 minutes. Same number of milligrams of bupivacaine, but given in a different fashion. And what the research on this has shown is that you actually get better blocks when you give these intermittent boluses. This may be in part the reason why PCA works so well, because with PCEA, patients are giving themselves their own intermittent boluses. But it seems you get a better spread of local anesthetic when you do these intermittent boluses than when you have a continuous infusion. So it's something that the technology is coming around. Some of the epidural pumps are now getting this option built into them. And I think this is one of the things that we'll be seeing much more of in the future. Okay. Something else. You've got a really sick cardiac patient for a cesarean section. Bad heart disease, let's say tight aortic stenosis, mitral stenosis, cardiomyopathy. You just imagine a really sick cardiac patient. Well, we generally use a technique called sequential CSE. And what this is using a low dose of a spinal anesthetic, not enough for a cesarean section, usually in the range of 4 to 8 milligrams. When we do this, we typically use 5 milligrams of bupivacaine. Again, not enough for a cesarean section, but just enough to sort of prime that spinal cord, get the block started. You inject this medication, minimal hemodynamic effects. You then thread the epidural catheter, wait, say, 10, 15 minutes for things to settle out, and then gradually start dosing the epidural, very slow incremental doses. And what you get is a very, very nice block with almost no hemodynamic changes whatsoever. And it's extremely useful in patients with all sorts of very severe medical issues where you really don't want any hemodynamic instability. For example, here's a study from IJOA, International Journal of OB Anesthesia. Low-dose sequential combined spinal epidural anesthetic technique for cesarean section in patients with significant cardiac disease. These were really bad cardiac. This wasn't like what I call social mitral stenosis, mitral valve prolapse. This was real bad heart disease. And they found excellent hemodynamic stability with using this technique. So something we have used at our hospital, you might want to try it for your really sick, medically compromised patients as well. Well, we used to keep people starving during labor. Moving on to another topic here. Recently, the guidelines have liberalized this. We now generally let patients drink liquids during labor. This is now standard practice within the United States. Actually, I'm just curious, in India, do you allow patients to drink clear liquids during labor? Raise your hand if you do. About half the hands went up. Okay, good. So the studies have actually shown that it actually helps with gastric emptying, makes gastric pH higher, makes gastric volume lower by having small amounts of clear liquids, and of course it makes the patients comfortable. This is supported by the practice guidelines of the American Society of Anesthesiologists, where it says modest amounts of clear liquids may be allowed for uncomplicated laboring patients. And again, this is how we practice at all of our places. But one thing that's interesting is, what about chewing gum? Well, believe it or not, there have been some studies on gum chewing, and it actually helps. It helps with gastric emptying, helps with gastric pH. There have been some studies on this after cesarean section. This was presented at SOAP, Society for Obstetric Anesthesia and Perinatology, just this past year. Effect of gum chewing on postoperative ileus after cesarean section. Previous study from a few years ago, gum chewing to prevent postoperative ileus. This was in bowel surgery, bowel resections. And what's been shown in multiple studies, these as well as a few others, is that chewing gum facilitates return of bowel function after surgery. It's actually beneficial. So we allow it. And in fact, this is also brand new. The European Society of Anesthesiology just came out with new guidelines on perioperative fasting for adults and children. And the results, or the summary rather, is that we encourage clear liquid. And I emphasize encourage. It's not like just we allow it. We actually encourage it. And sometimes I'll see a patient preoperatively and I'll tell them, you can drink up to 2 hours. And they'll say, oh no, I can fast. Okay, I don't need anything. No, I say, I'll be done in about 2 minutes. I would say, we want you to drink. It actually makes things better. Same thing for gum chewing. We encourage the gum chewing because it actually makes things better. So the case is finished. My one last point, you've put an epidural in, case is done, you go to take out the epidural and it's stuck. can't get it out. You pull and you pull, you can't get it out. What do you? Well, besides worrying, one little tip you can use. This is something we just did. A case report we just had published. Many of you may have used this technique as well. You want to try to make that catheter a little stiffer to make it slide out. If you take some saline, put some saline at the end of the catheter, and then pull right where it is at the patient's skin, just as you're injecting the saline, that'll make the catheter stiffer, and in most cases allow it to slide right out. So epidural saline to facilitate removal of a stuck epidural catheter. Just a little tip that might help you in that situation. And I'm going to end 1 minute over time, but I hope these have been useful tips, and I hope that maybe you'll incorporate this into your own practice. And again, thank you for having me here.